Welcome, everyone, to the episode focused on the science of immunology as part of the series that Lifebulb is working on together with ITB-MED. So thank you, ITB-MED, for sponsoring this series. Today, I am joined by Dr. David Sachs, who will introduce himself. And I am Karin Heerberger. I am the president of Lifebulb. And I have a personal interest in transplantation in the sense that I have gone through 3 organ transplants, 2 kidneys, and 1 pancreas. But I'm also trained as a medical doctor and a PhD. But I truly am honored to be here together with Dr. Sachs, who has a tremendous experience in transplantation in the science of immunology, which is the topic of today. And I want us to focus on transplant in the overall aspect of immunology, and also discuss what tolerance means, again, with focus on transplant. So, Dr. Sachs, welcome, and please give us a few words about yourself and your background.
Well, thank you, Karin, and thank you for inviting me to speak with you today. I've had a long history in the field of transplantation. I have also a personal interest in it because I've worked on it for so long. I got interested in transplantation when I was still in medical school, when I heard a lecture about tolerance. I thought, well, there's something I would like to work on. At the time, I thought I would have it all solved in about 5 or 10 years, but it's taken me quite a bit longer. I've found it challenging and interesting the whole time. I'm a professor of surgery and medicine. I was at Harvard Medical School for many years. I still am at Massachusetts General Hospital, but my academic appointment is now at Columbia for the past 6 or 7 years. I moved some of my work to Columbia, but I work at both places, both Harvard and Columbia. And my concentration has all of this time been on transplantation.
So let me ask you, because I think it is fascinating, the area of transplant, because it's a mix between science and surgery, pretty, incredible surgery when you take an organ from someone else and put it in the recipient's body and it works, right? It must be a very rewarding surgical procedure. But then, of course, the immunology of that is complex. And then you lay on top the philosophy and the ethical perspective of using an organ from someone. What was it within all of those different categories that really attracted you to the field?
Well, that's a good question, Karin. I've thought about it myself many times. I'd say I was always interested in research and also in medicine. And I saw transplantation as combining, as you said, basic research with clinical application. And it's one of those fields where you can actually do both. I originally intended to both be a surgeon and a researcher, and I started out that way. I did my medical school at Harvard, and then I started a surgical residency. And I took 2 years from that residency to do my military service. And I was stationed, as it was, in the public health service at NIH. And I went down for 2 years, and I stayed for 21. I became the chief of the immunology branch of the Cancer Institute. And by the time I came back to Mass General, I was a professor of surgery, but I hadn't really finished my residency. So I'm not a fully qualified surgeon. I've done some surgery, but I'm not a fully qualified surgeon. But I've stayed in the field of transplantation. I've had many surgeons working with me all through the years at Mass General. I got interested mainly because of tolerance. When I heard a lecture in my second year of medical school, and that was when it was really, transplantation was in its infancy still. That was in 1965. And I was attracted to that because I had been looking. I had done organic chemistry previously. I had done organic chemistry in college, and I had done the equivalent of a master's degree in Paris in organic chemistry. When I came back to medical school, I knew I wanted medicine, but I knew I also wanted research, and I was looking for the field that might attract me. And when I heard this lecture about tolerance, it hit me that this was something which could, everybody in medicine comes with some sort of a disposition toward trying to see who he or she wants to help. And I saw this as a way of helping a person in the prime of life with so much still to be able to contribute and to enjoy, who's being struck down because one organ has failed or one tissue has failed, and the possibility of restoring a normal life to that person really attracted me. And when I heard about transplantation, I immediately asked the lecturer, "Who's doing it around here?" And I started working with Dr. Paul Russell at the Mass General Hospital at that time. So it's been a long time, and it hasn't disappointed me at all. But it's been, I would say that it's still very fascinating to me.
Yep, no, absolutely. And immunology, I mean, even you go back to medical school in the 1960s. For me, I was in medical school in the 90s, and the immunology that I studied in the 90s is very different than the immunology they study now. We were still studying the mouse system, and now we have much better understanding about human immunology. And I do think that the cancer space has led the way to a certain extent. I mean, they're in the autoimmune space. And of course, transplantation is probably the best application of immunology, because as you said, you're taking a person who is per definition in failure, organ failure, an end stage disease, and giving them an opportunity to not just fix that organ, but to continue to live their life. And I see that again, in my N of one example, it got me back to be productive, to live a full life, and to even be able to have a daughter. So that is extending life to someone else. And that is absolutely fascinating to me, the overall perspective of transplant. So if you go back to immunology from a patient perspective, that's a word that has been used a lot lately. People know about COVID and vaccines, and it's been used and maybe misrepresented in some aspects. But if you were to explain to someone, what is the science of immunology, again, with a focus on transplant, how would you do that?
The immune system is there not to prevent us from doing a transplant, but to fight off invaders like bacteria and viruses. It's there to recognize what shouldn't be there when it tries to invade your body. So the immune system looks for differences from self. Mm-hmm. Now, there are the way the immune system works is we have two kinds of cells, lymphocytes, T cells and B cells. T cells recognize antigens, and they can actually turn on the B cell to make antibody against those antigens. Now, antigens, when I talk about antigens, we're thinking of anything that is different from what is self. Now, how do we decide what's different from self? Well, the immune system has built into it a way of determining what is self and what is not self. As T cells develop, and they develop in the thymus, so they encounter the self antigens and they become tolerant to them. If we didn't have that ability to naturally develop tolerance to our own self antigens, we would all have autoimmune disease, because we are constantly making new T cells all the time. We're making new T cells, and that's the center of the immune system. And these T cells are there to recognize things that are different. As they develop, everything they see is different at the beginning, but then we have what's called negative selection that occurs in the thymus, where those cells that react against self are eliminated. And that elimination, that negative selection, leads to tolerance against self. Now, some T cells escape that process. And even though they've gone through the development in the thymus, they go out into the periphery, and occasionally they do start to react against self-antigens, and people do get autoimmune disease. It's much more common than people realize, but most autoimmune disease is fairly easily overcome by medications, and it often goes away. But some are much more serious. The way that the immune system has handled those T cells to prevent the autoimmunity is by developing another kind of T cell, which is a regulatory T cell that downregulates the reaction of those T cells that shouldn't be there, that are reacting against self. So we have two ways of inducing this tolerance. Tolerance is the absence of a response to an antigen. And it used to be called the absence of a response, and it still is. But we know now that you can get tolerance both by the thymus eliminating the cell, or by downregulating the cell that has formed, the T cell that has formed that reacts with it. So the immune system has naturally developed two ways of inducing tolerance for self to avoid autoimmunity. Well, I say to avoid autoimmunity. That's what we think. nobody knows exactly how all of these things evolved, but it makes a lot of sense that the immune system evolved during evolution to avoid autoimmunity, and has therefore come up with these ways, the negative selection in the thymus as a T cell develops, and regulatory cells in the periphery as when they to prevent T cells that do still react against self from causing damage. So both of those can lead to a state of tolerance where you don't need immunosuppressive drugs, where you no longer react against a donor even without immunosuppressive drugs. So that's how we use that same system that's there to prevent autoimmunity, to prevent immunity to the particular donor who's going to donate an organ
So
or
let
a
me ask
tissue.
an example that I often get from patients, which is, what about pregnancy?
Well, that is very interesting. It turns out that the pregnancy, during evolution, in order to avoid rejection of the fetus, very special mechanisms evolved that in the blood in the system in the trophoblast, which separates the fetus from the mother. There are very special systems that evolve that prevent sensitization from occurring and prevent the rejection of the fetus. But as you may know, the more children a woman has, the more at the time of parturition, of childbirth, there are enough cells that can escape across the placenta to immunize the mother. And the mother therefore makes antibodies against antigens from the father that are also in the fetus. And that's in fact how the whole typing for HLA began. It began by, when I first started, we were screening multiparous females, as women who have had multiple babies from the same father, to look for antibodies against the antigens that were causing transplants to reject. And that's how the whole field of transplantation in humans got started. And so it's been a long history, but that is when I say tolerance, I'm usually talking now not about self-tolerance, but about tolerance that we induce to the donor of the tissue that we want to transplant. But it's using the same mechanisms that are used to avoid autoimmunity.
Yeah, I think that's a great explanation for the immunology portion of the session, the way that cells recognize self, and that some cells are escaping and therefore autoimmunity can occur, like type 1 diabetes, where cells are attacking the beta cells
exactly.
The cells are being destroyed. Personally, that's what happened to me, and that's why kidney failure, that for some reason, the beta cells in my pancreas were suddenly not recognized as self, and my immune system started destroying them. So with the same mechanisms that are being used to experimentally induce tolerance in a recipient for a donor, one could argue that if one just changes the antigen, then one could also reduce the autoimmunity of the beta cells in the type 1 diabetic person.
That's very good. Well, very well explained. Yeah. In fact, you see, it's interesting that the same drugs that are used to prevent a transplant from rejecting are the drugs that are used to prevent or to treat autoimmunity. The advantage that we have in the field of transplantation over the autoimmune field is we have an immune system that hasn't yet seen the donor, and we know what the donor is going to be. So we can start the process of inducing tolerance in advance before we put the organ in. In autoimmunity, we don't know who's going to have it until they already have the disease. So we have to fight what's called a sensitized T cell in order to induce tolerance in a situation of autoimmunity. But they really do represent a similar kind of reaction. And it's the opposite side of the coin from cancer, which you also mentioned earlier, Karin. In that case, we're trying to get the immune system to react against the tissue and get rid of it. In the case of tolerance, we're trying to prevent the immune system from getting rid of something we want to keep. The two sides of the same coin.
Yeah. So going back to transplantation and immunology, as you mentioned, we know the donor and we know the recipient. So what can we do pre-transplant to understand how we can induce tolerance, or how can we induce tolerance in the recipient?
Well, as I said earlier, the way that the immune system gets rid of cells that we react against self, the first one is in the thymus as T cells develop. So the way the T cell is eliminated by negative selection is by reacting as a new T cell is forming in the thymus, is reacting with cells which are a special kind of cell called the dendritic cell, which comes into the thymus from the bone marrow, from the blood, and is made in the bone marrow. What we found a long time ago is that if you exchange the bone marrow, and we do this for a bone marrow transplant, generally for a patient who has leukemia or lymphoma, has a hematologic malignancy, that if you can get a bone marrow transplant to be successful, now you have an immune system from the donor. That donor, that immune system now will not reject any other tissue from that donor. Now, obviously, we didn't do the bone marrow transplant for that reason originally. We did it for leukemia or lymphoma, but there were cases where such a patient then needed a transplant later on of a kidney, for example, and could get it from that same sibling who gave the marrow for the bone marrow transplant. Those always were accepted as well. So now, in general, bone marrow transplants were only done between HLA identical siblings.
Well, 6 out of 6?
Well, it's more than that even, because you see it's 6 out of 6 for sure. But there are lots of other genes in the HLA besides the ones we can type for. And if they're siblings, they got the same ones from both parents. Mm. So if the parent had 2 chromosomes, A and B for the mother and C and D for the father, all the siblings are either AC or AD or BC or BD. And so if you were fortunate enough to have a sibling who had the same HLA from those 2 parents, you have all the genes identical. Yeah. Now, when you say 6 antigen match, that's also true even in the outbred population. Just you can find 6 antigen matches, but they're not as good as a family sibling because they do have other differences as well. So that was the way we first realized that we could get tolerance through a bone marrow transplant. Now, unfortunately, when you do a bone marrow transplant, the reason you're doing it is to replace the marrow. You want to get new marrow from the donor. Now, there are 2 problems with that, and we know that will induce tolerance for an organ transplant. But the 2 problems are, number one, that if you do that, you have some of the risks that you have from transplantation, which are much greater if you cross an HLA barrier, a major histocompatibility barrier, than they are if you have an HLA identical sibling. But that's even true for HLA identicals. There are other antigens that are not linked to HLA. So the problem with a bone marrow transplant, especially if you want to go across HLA, is you can get graft versus host disease. And that can be worse than the problems you have with immunosuppressive medications. And the other problem is that if you go across an MHC, an HLA barrier, the T cells and B cells don't react very well with each other. Not as well as they would if they were from the same donor. So what we worked on was something which we call mixed bone marrow transplantation, mixed marrow, where we don't get complete replacement of the marrow like you need to do when you're treating a patient for a cancer of the lymphoid system, like a lymphoma. You want to get rid of every last lymphoma cell. So you want to replace all those cells with donor cells that don't have cancer. Mm-hmm. But in fact, to induce tolerance, you don't need to replace them all. You just need to replace a small fraction of them so that you'll have negative selection against that donor as well.
So you're saying that even if you have a number of cells that are the same that you had before, even if you have some of the new ones that will recognize the antigen on the organ, meaning the kidney or say it's the kidney, then those cells will come out and recognize the kidney and will remove the risk of rejection.
Yeah, they will come out. They will look at that kidney as self, just the way they would if they were being eliminated because they were reacting to self.
Yeah.
So that's the idea of what we call central tolerance or deletional tolerance.
Is there a number of cells that need to constitute the total percentage of the bone marrow from the donor to embrace the kidney, as I would call it?
Well, nobody really knows the answer to that question. You'd think we would know it already. I do know that in mice, it doesn't matter whether it's 1% or 10% or 50%, and you can still be tolerant. But if it's 0%, you don't become tolerant. Right. So we know you need some mixture of bone marrow in order to get this kind of tolerance. But fortunately, now in the case of when we go from mouse to pig to monkey to human, which is how we do this research, and it turns out that in the human, it's much harder to get long-term lasting mixed chimerism. Mm-hmm. You can get it for a while, but then it disappears. And that's then what I thought originally when we first started doing our studies of trying to induce tolerance through mixed chimerism, when the chimerism disappeared, and this happens in the monkey as well as in the human, that we would lose tolerance, but we didn't. Well, why didn't we? It's because there is also these regulatory cells they form, the other kind of tolerance. It's not really the absence of an immune response. Now, we changed the definition of tolerance for transplant from the absence of a response to the absence of a destructive response, because this is a positive response. It's a response that downregulates the rejection. So fortunately, that took over. And the patients didn't, the monkeys and now the patients did not lose the kidney. If we put the kidney in while the recipient has a mixed chimera, and again, I don't know exactly what percentage we need. My colleague Hatsu Kawai at Mass General, he would like to have over 5%. I'm not sure what number is the lowest you can have. Clearly, the more the merrier. But it doesn't stay permanently. It's what we call, it's a transient chimerism, but you still can induce the tolerance for that kidney. And after the marrow disappears and the patient goes back to being just self for all of their lymphocytes and hematopoietic cells, the kidney still remains and the patient remains tolerant.
And that is because of the regulatory T cells that are in the periphery.
Right.
And they are transformed, or they are now being induced, or they have been induced by
They were induced originally and they keep getting made. And the kidney is sufficient to give that stimulus to continue them being made. And that we've shown in our animal models, because we can take out that kidney and put it in another identical animal, in an animal model, and we can induce tolerance.
You looked in the bone marrow of the origin of the T regulatory cells and seen that there's a genetic change, or is it an epigenetic change in the T regulatory cells?
The T regulatory cells, they form in the thymus, and they are host type cells that regulate host reactions, just like they would to prevent autoimmunity. But now they're preventing rejection of a graft.
Right. No, I'm just saying that the original T regulatory cells that were made before the chimerism, they were not tolerant to the kidney that was the donor kidney. And after the chimerism, the new T regulatory cells that are being manufactured by the thymus, they are slightly different. They now recognize. So there must have been a change in the production of the T regulatory cells, either at a genetic level or at some sort of epigenetic level.
Absolutely. Absolutely. And this kind of question is under study. The mechanism by which this tolerance is maintained at a molecular level, cellular level, and whole animal level is being studied in the laboratory, both really our laboratory and other laboratories.
Okay. I'd love to learn more about that in a separate session. That's really interesting experiments, because then we can really figure out maybe how to manipulate the T regulatory cells without the chimerism.
That's right. That's possible.
Yeah. Interesting. Okay. So I think we have a good understanding now of, at least beginning of an understanding of tolerance and how this. Would you dare to just talk about the practicality of this? Because you've talked about the mice, the pigs, the monkeys, and now man. Have you seen any early data on people who have done this to, and how long have they gone without needing to use any immune suppression?
Well, it's the first patient that we did with this we started this, of course, in patients who were HLA identical. They were patients who had myeloma and who had one of the problems with myeloma, which is a cancer of the bone marrow cells, is that they frequently they make a protein that really piles up in the kidney, and they get kidney failure. And so these patients, we had some patients who needed a kidney but had this malignancy, so they couldn't get a transplant, and they couldn't have further treatment. They already reached the end of the line for treatment for the myeloma. And so these patients, and there were some of them who had HLA identical siblings, which is the only cure for myeloma, and which did that and showed when we induced chimerism in those patients, they became tolerant for a kidney transplant. And the first patient that we did on that is still alive now, 40 years later. And she came to us and said, I'll volunteer to be your first patient because I want to be alive for the birth of my first grandchild. She now has 5 grandchildren, and she's still doing well. So then we moved on to HLA mismatched, which is a much more common situation. If you're unlucky enough to need a kidney, but lucky enough to have a sibling, an HLA identical sibling, that really works well and needs very little immunosuppression. But we wanted to move on to the more general case of HLA mismatch. Mm-hmm. And the first mismatch is then we moved to mismatch, and the first mismatch patient that we did also, it did beautifully, and she's now out. I guess let's see, she's out 20 years, and
No immune suppression.
Well, that's correct until about 2 years ago when she started to have, she still has no, she has perfectly normal kidney function, but she started to show evidence we test periodically the blood to see if there's any evidence for donor reactive antibody. And she started to have a low level of it. So she was put back on as a precaution. No change in her renal function and a biopsy was still normal, but they put her back on to some immunosuppression, low dose after something like 18 years. So she's just done beautifully. Now, not every patient has done that well, but 7 of the first 10 were able to be taken off of all the immunosuppression and have stayed off for a period of 7 of them for over 5 years, and 4 of them were already over 10 years. So it's been around for a while. We had to stop after that first trial. That was sponsored by the NIH. And we had to stop because one of the drugs that was very essential for inducing that tolerance at the very beginning. At the beginning, you have to get the bone marrow to take. And so it does take a lot of manipulation of the immune system to do that. But then afterward, we could trade that for getting off of all drugs and have a whole life without drugs and back to being absolutely normal. So that was the goal. And so we wanted to do that for more, but one of the drugs we were using became unavailable. And it took several years, but from the first series of studies that we did to now.
This is remarkable. I really appreciate this conversation. And it's very hopeful because not only as a person who's living with these 3 transplants, two, one is, my father's kidney is no longer really functioning, but 2 functioning transplants and all the patients that we serve through LifeBulb and Transplant Life. And of course you serve, and everyone who's in this space, is looking to help and impact patients. We want to give them a life back. We want to give them that life where it's not just the surgery it's a successful surgery. Patients are out of the hospital, maybe after 4 or 5 days. But then living with the transplant should not be another condition of kidney disease. It really should be a way to continue to impact other people and to live a full life again. And for that, we need better treatments. And I think that's what you've been dedicating your life to and what we want to encourage and we want to showcase through these kind of seminars. So thank you. Thank you for doing that. Thank you for your time today. And I really hope that you will come back and talk to us again. And personally, I want to thank you for what you're doing. And I hope that at some point, I get to experience this to live a life without these immune suppressive medications on a daily basis. Thank you.
Thank you, Karin.